There you are. So yeah, very nice to see you both. So we gathered here today just to have an informal fireside chat on digital pathology, artificial intelligence, to reflect on our experiences, and nothing formal. So this is just three friends having a chat about a topic. So hope that whoever sees this video finds it of interest, and hope to maybe convey one or two practical lessons from the trenches out there. So, shall we get started with introductions? So, perhaps Sarah, would you like to say a couple of words about yourself?
Sure. So my name is Sara Oliveira. I'm a postdoctoral researcher at the Netherlands Cancer Institute in Amsterdam. And I've been working with computational pathology since my PhD that I finished in 2022. Back then, I worked mostly with, slides or all slide classification. And now I moved a bit more to a more refined tasks and trying to characterize the microenvironment using both H&E and immunohistochemistry, all with AI models, of course. And yeah, that's it.
Sounds good. Luca, what can you tell us about yourself?
Ciao Juan, ciao Sara. My name is Luca Di Tommaso. As you know, I am a pathologist and I've been working several years as a liver pathologist. So I am a professor of pathology at Humanitas University, and my research activity until 2019, but still nowadays, was focused on liver pathology. But then in 2019, I fell in love with digital pathology. I became aware of this possibility of the clinical feasibility of this solution, and I started working with people interested in the topic. And at first I tested during the COVID year. In our hospital, we tested all scanners and viewers that were available at that time. That was the correct period to test this. And then in 2021, after the pandemic ended, or at least the most critical point ended, I started guiding the digital transition of my hospital. We are about 20 pathologists, 10 residents, some consultants, so about 30 people involved in the procedure. And we are now almost close to the end. So the path lasted 3 years, but we are now fully digital. And I'm now interested in digital pathology, not only in terms of clinical practice, but also in terms of research. So I'm doing some research on this topic, and also on artificial intelligence. I'm working on artificial intelligence applied to digital slides.
Wonderful. So my name is Juan Retamero. I'm also an anatomical pathologist. I'm based in Spain. I got first started in digital pathology back in 2016, when the lab I was working on became one of the first labs to go fully digital for primary diagnosis. And back in those days, I'm not sure if we were the first, but maybe we're second or third to achieve full digitization. So it was quite novel. We had the ideal situation in which an astral alignment occurred, in which we had public investment, we had a vendor that was willing to provide all the elements required, and also we have an IT infrastructure that permitted us going very quickly from the microscope to full digitization. It took us 4 months. So it's good that that we can reflect today on our experiences, going from the deep dive into the deep end approach that we follow in Granada versus what Luca did, which is more, slowly, perhaps more gradual approach to the same target, really. So this is something that we did back in 2016, and today I work for Page. I've been with the company for about 4 years and some months. I guess, once you go digital, the idea is, digital pathology is great in itself, but obviously we all want to go one step beyond, and what step beyond is obviously, putting those pixels, train some algorithms, and hopefully get those algorithms to help pathologists do what we do day in and day out. So yeah, so I guess, that leads us to the first topic for discussion. But of course, there are no topics as such today. But I guess, what is it, in your opinion, more recommendable to go from a quick transition or rather slow span out transition when it comes to digital pathology adoptions? I guess the benefits and drawbacks from each, but what's your take there, Luca?
Great question. Probably difficult to answer. Maybe
Yes.
there is not only one answer or the correct answer. Maybe the situation can be different and the answer can be different according to different situation. Let me say that in my experience, let's say slow transition was the best solution for our hospital. What I mean is that taking into consideration residents, and we have 10, a fast solution will be the best one. But we have also 20 pathologists spanning different age of experience. And to what I realized during these last 4 years, people who have been working with a classical microscope, our friend, for a long time, do not feel so confident into leaving away the microscope and using a monitor, a PC, to do the diagnosis. So to get a short answer to the question raised by Juan, if the Department of Pathology moving digital has few pathologists, maybe a fast solution can be adopted. But if the department has several pathologists spanning different age of experience, maybe a step-by-step solution is a little bit better, starting from people who are really committed to digital transition and then involving also the other colleagues.
Yeah, I would tend to agree with that. I mean, from my perspective, our situation was quite unique in the sense that, we were 23 pathologists, of course, spanning from, ages, from very junior pathologists to very senior pathologists. And, not everyone was a big fan of going digital, as you can imagine. And, that is not an understatement in the sense that there were people who were opposed to the idea of going digital. And of course, you have to manage these pathologists and, of course, provide them with, what they require in order to transition safely and comfortably to digital pathology, which can be achieved, of course. And I guess the human change element is one of the main topics that we have to contend with when it comes to digital transformation. Generally speaking, I would favor a quicker transition because in my opinion, a hybrid approach is somewhat problematic in the sense that somebody has to decide what slides go for normal distribution and what slides go to the scanner. And human beings are human beings, and of course we're prone to error and we'll make inevitable mistakes. And the slides that are due to go to the scanner sometimes ends up in somebody's desk and the other way around, and that creates confusion and creates delay and whatnot. It could be that we were just disorganized in that sense, and perhaps your lab is better organized in that regard. But my point is that there is no right or wrong, and there's different ways to approach this task, and I guess the plan really differs on your institution, their needs, their feasibility, the availability of infrastructure, etc., etc. So long story short is that there is no right or wrong, but of course, has to be a solution that works for you, given your constraints, given your resources, and given your overall availability of mediums. Any other comments here?
Let me say one important thing that I realized during this experience in Humanitas was that IT persons, so engineers involving in the management of the infrastructure of the hospital, should be part of the project. Not only pathologists, but also they should be part. And indeed, at least in our hospital, the project manager was an IT person, an engineer, a very smart one, and it was essential, really essential to support pathologists, because maybe you know that pathologists can be somehow problematic for these technical aspects sometimes, so it's better to have someone who can really help them.
Agree. I guess, it doesn't really matter which route you follow to get there, as long as you get there, because, in my experience, digital pathology does wonders for pathologists. So, in terms of improve efficiency, improve safety, improve diagnostic accuracy, I think this is something that is very realizable with digital pathology. Things that you cannot really do on the microscope become a reality with digital pathology. So in your opinion, and of course, Sara, feel free to chip in as well.
Sure.
What do we think digital pathology does for pathologists?
Well, maybe I can start and then Sara can add something. All the things that you said, Juan, were perfectly right. But basically, after 5 years, maybe it's 4, but anyway, after a long period working, working with digital solution, the most important thing, according to me, it's my desk. If I look at my desk in front of me, it's free of anything, no slides, nothing, clean, and my mind feels better because of this. I can do everything working on the PC. Do I have to look again at an older case, meaning 1 week ago case? I just go to the list, ask for the case, and I can retrieve it in a few seconds or less. Or do I have to share a case quickly with a colleague, let's say an oncologist, asking me in a very angry way, you missed some point. I just link on the case, activate a web meeting, Teams or whatever you want, and share the case with this person. And I can also share the case and show him or her what's the diagnosis and why I diagnosed it. So let's say that this is, at least for me, the most important thing. My working life, it's easier.
Yes.
Easier. Everything can get easier. That's the most relevant aspect to me. Then, of course, there are some important aspects in terms of efficiency and time saving and so on. But I don't care of this. I'm here to work, and my working experience is better than it used to be 5 years ago.
Yes, I agree. I guess, we're not aware the amount of time that we spend looking for slides, dealing with slides that do not appear, slides that get lost, the slides that happen to be on your neighbor's desk when they should be at your desk, and the other way around, of course. And we're just not aware of that. Like, every day of your working life, of your profession as a pathologist, somebody knocks on your door and delivers a slide tray with immunostains. And that happens every single day of your career. And your next 5 or 10 minutes are going to be spent matching each immuno with the corresponding H&E. And you do that every day of your career, unless you have a fellow, which is something that happens to academics. So probably Luca is not too concerned about this issue. But those of us who used to practice without a resident or without a trainee, we had to do that ourselves manually. And that takes time, of course, and that is time consuming. And, sometimes, the wrong immunos end up in the wrong desk, and you have to chase the right pathologist for that. Anyway.
Or ask again the immuno.
Right.
If you ask again, so waste of money also. It happens, unfortunately.
Indeed. Point is, the logistics of dealing with slides get so much improved with digital pathology. And I guess, this has repercussions not just in the clinical setting, but also in the research setting, doesn't it, Sara? In the sense that, finding the patient and the case that you want almost immediately is important, not just for clinicians, but also for researchers.
Definitely. And when it comes to computational pathology, we are nothing without digital slides, right? So just that fundamental point of having images instead of glass slides. Of course, it enables all my area and all my research. But of course, I wouldn't say that it's perfect, because as human errors occur also in the digital setting, errors can occur, of course, and we have to be aware of that. But definitely case management, at least from what I've seen and being from the outside, not being a pathologist, of course, case management is way easier. Discussions become way easier, right, among colleagues. And even then we have the research, of course, and all the development of tools that can help pathologists being even more efficient in terms of case handling, right, and diagnostics and whatever you want to do.
Indeed, yes, and I think efficiency is an important element associated with digital pathology. And back in the beginning, really, of a digital transformation, or rather 3 years after having gone digital, we did look at efficiency numbers and check whether we have become more efficient after having gone digital. And in fact, pathologists were able to sign out 20% more cases compared to the microscope days. And when we published these results, people just didn't believe us. It's like, this is totally impossible. It's just not doable. And in fact, when you think of, the fact that you don't spend time looking for slides, you don't waste time looking for immunos, you don't waste as much time preparing for tumor boards, for multidisciplinary meetings, for things like that.
Yeah.
If you start adding up these little time savings here and there together, aggregated, that's how you get your 20%. And in reality, that's how you get your return on investment. Because this is another common topic, another question that we classically get. It's like, yeah, this is all great, but the microscope costs what, 5,000 euros, and a digital pathology scanner easily costs $250,000. So how do you pay for that? And in my opinion, this is how you pay for it. You have a pool of pathologists who is all of a sudden more efficient and capable of dealing with more cases that you're going to get anyway, because what happens in most public healthcare, not necessarily European public healthcare settings around the world, but pretty much across the board, you get more cases and fewer pathologists to deal with this growing number of cases.
That's true.
Yeah. So, and interestingly, we have recently papers coming from the European Society of Pathology, basically stating that, well, these increases in efficiency provide sufficient return on investment to justify going digital in the first place, and probably leave some money on the table in addition to that. So yeah, just wanted to hear your thoughts on that subject.
Well, let's say that I don't have number to support your sentence, so we did not investigate this aspect. What I know is that in the last 3 years, we moved from 55,000 cases per year to almost 70,000 cases per year, and the number of pathologists did not increase at all. So perhaps this is the result of the greater efficiency of each pathologist, or at least each digital pathologist. Let me focus your attention, yours and Sara's attention, on the other side of the moon. What I mean is that the technical part of our department, the technician, which are essential for our work as a pathologist. What I realize, and indeed of this I'm quite sure, is that the digital transition helped their work. If you think about the Department of Pathology, we have at least a couple of technicians distributing slides, assigning cases to pathologists, doing a sort of puzzle activity, putting a slide A1 with A2 and then A3, which is a nightmare if I am in their place. And this is
it's not the most intellectually challenging job in the world.
Definitely. And they can create a lot of problems, which are then faced by pathology. Now this story is not existing any longer.
Right.
Once slides came out from the staining machine, they are put exactly in this way, directly in the scanner, and then from the scanner to the archive. Also, so we also do not need any longer an archivist, so a person doing or taking care of the archive. So there are at least a couple of even 3 technicians which are not any longer requested by, and they are substituted by the activity of the scanner. And to be honest, they can be used to do other work such as cutting or staining or something like this. So I don't have an answer or some personal data to support the sentence of Juan, but I have some data regarding the technical experience in our hospital, and our technicians are really very happy with this solution.
Yes, I totally subscribe to that. And this is something that I've seen throughout the many labs that I had the pleasure of working with. It's like, slide distribution, case assembly, slide sorting. It's actually, a bottleneck in any lab, any analog lab, because, let's say that, the average lab produces 1,000 slides every day. Somebody has to put order in that chaos, and somebody has to match, all of the slides with the corresponding remaining slides from that case in order to put the case together and match that and send that to the right pathology. And that is a logistic issue, obviously. When everything is digitized straight away and the barcode actually matches the right image with the right case with the right pathologist, that happens automatically behind the scenes. So I totally agree with you, Luca. You have 2 or 3 people that normally take care of that task every day, and it's no longer required. So these technicians can be doing more meaningful tasks, like dissecting, for instance, which is something a machine cannot do, right?
And they are not requested to supervise the scanner. I mean, when we started this digital transition, people told me that the scanner should be supervised by a technician every minute. It's not the case at all.
No.
Obviously, you have a technician you need a person to check the procedure and so on. But basically, it's just less than 1 hour per day per scanner, obviously.
I agree.
And also the retrieval of cases from the archive, which is more or less 10% of our daily activity, is done automatically by the scanner, by the digital slides, so by the digital solution in the archive.
Right.
And also this is important for research purpose, just to go and talk with Sara about this.
Definitely.
Because we can retrieve cases so quickly and address quickly the answer of researchers. So.
And I would say not only for research, but if you think in a long-term storage, if you have to revisit, I don't know, some case for some reason, being digital just makes things way easier. First of all, because it's all better stored, right, and better organized. But more than that, the quality of the slides don't degrade with time, right? So you have the exact same information that you just had before. So I think it helps. And for research, definitely, we don't have to have fresh cases. Let's see, we can go back in time if it was digitized, of course, and we'll have the same quality that we had back then. So, of course, it makes things way easier and way better, definitely.
Agree. Shall we switch gears? Because we I think we are all in agreement that digital pathology is desirable. Digital pathology makes for a more efficient and more pleasurable environment for pathologists to work in. I think we're all in agreement there. And of course, Sara mentioned earlier that it is the foundation of artificial intelligence in pathology, without which, obviously, you cannot apply AI to a glass slide, can you? So, what in your experience, what does AI do for pathologists today? And of course, Luca, you and I had the pleasure of collaborate together in a small prostate pilot project some time ago. And that's how we became friends and got to know each other a bit better. And it was quite an interesting project, wasn't it?
Yes, it is, definitely. Indeed, when I started working digital, at the very beginning, I was thinking to artificial intelligence application. Then in the meanwhile, I realized that the digital transition make my daily activity easier. But at the very beginning, I was interested in AI tool. In my mind, at that time, when we met and we started working with your solution, the idea was that something like this: is there any solution AI which can help my work to become easier in terms of focusing my attention on what I should focus on? Let me tell in another way. I am a pathologist, but I also I am in charge of cytology here in my hospital, and I am a fellow of cytopathologists. So I manage 4 cytotechnicians. So they screen the cases for me and they point my attention to this, which is exactly what residents sometimes do or fellow can do. So I was thinking at that time, is there any AI solution which can do this? And then I met Juan and his company, and I realized that the answer was yes. There is something which is available at clinical level. Maybe still nowadays, 2025, the number of solutions which can be used at clinical level are few, but I think we are at the beginning of the path. And maybe Sara can tell something more about this, about the possible application of AI on this.
Yes, so usually I see this in like 3 ways, like all the kinds of models that we develop and that can be applied in clinical practice. The first is like helping you with a bit more like routine tasks that you just have to, for example, checking for normal versus tumor sites. So doing this sorting that can kind of be easily done by digital pathology. So more easy tasks, let's say, that you always have to do, but that can be helped by AI. Then second, more on the diagnosis point of view, so helping you looking for certain areas, having like a second opinion. So like having a second pathologist, but it is an AI model doing all sorts of tasks, going from grading to diagnosing to detecting tumor regions within a slide. I don't know, all kinds of models. And then the third one that I find the most interesting one, that is like going beyond what we already see in the image and trying to conjugate first multiple data sources, right? It goes to omics, it goes even with radiology, I don't know, multiple sources, and trying to go further the line, trying to, I don't know, link cases with prognosis, trying to have like novel discovery and checking for patterns that probably you usually don't see in your routine, but maybe they are even there, and then we can extract that. And I think that is like super, super interesting, and what like kind of drives the field forward. But definitely, I think AI can help you in multiple ways, as long, of course, you are digital and you are you work easily with a digital setting, and you are aware of these tools. So, in my opinion, I think pathologists should embrace AI as a help, not a substitute. I think we won't be there. Well, maybe in the really long future, but or at least the way I see this, like we are developing tools to help you and not to replace anyone, or just to make the process and diagnostics and the pipeline better, I guess.
Totally agree. I think, Luca and I were far too young when immunohistochemistry came about. Certainly, I was not practicing pathology. I was probably practicing kindergarten activities when that came about. But the point of the matter is that people reflect on those days as if, the same fear or concerns were present, like, immunohistochemistry is going to change how we practice, and it's probably going to render pathologies obsolete because, now an immuno can tell you things that, you would require a pathologist today. And of course, it all became very clear that immuno was just a tool to help pathologists, do what they do. And so I was old enough to have reasoning when molecular came about not that long ago, but same kind of situation. Oh, well, what happens with those problems that, a pathologist was required to elucidate, and now a molecular test can tell you whether, this could be, I don't know, a P53 tumor, and you could just treat that straight away, and that's going to render pathologists obsolete. And again, something that was totally unfounded. It is just another tool, isn't it? So
if not for more, like when you are dealing with a case, it's not only the slide that you are looking at, right? It's not only an H&E slide that you have to see. There's all the other conditions that the patient may have. There's all the other modalities that you have to check. So there's this combination. And of course, nowadays, like multimodal AI is a big thing, and we are trying to bring everything to the same model to have a more comprehensive view on the data and on the cases, of course. But still, making these correlations and putting all these data together, I think you still need a pathologist to that. There are some questions that only the pathologist can make. And I mean, even though the models are definitely progressing and being better and better at each time, we still need this human perception and these human questions behind to put everything together, in my opinion. So definitely another tool. The more you know how to use these tools in your favor, I think the better pathologist you will be.
No question. You still require a human brain to interpret what an AI is telling you.
Exactly.
Same way as you still need a human brain to interpret, an NGS report. And the same as you need, a human brain to report an immunohistochemistry, isn't it? Is it staining the right cell population? Is the staining the right type of staining, whether membranous or nuclear or cytoplasmic, whatever the case might be? We still have to interpret things, and AI is not.
And if not for more, sorry, Juan. If not for more, there will always be rare cases, right? So even if you have a lot of data that you train your models with, you can simulate the entire world, right? There will always be something that will deviate from what you have trained with. So if you think of these extreme cases, we can discuss if AI will be ready or will be as good for these as it was before, even though you trained it with a lot of data and the performance is like very good already, right?
Yes.
Maybe one important thing, I don't know, Juan, what is your idea, and also Sara. Do you think we need a guideline to use AI at clinical level? Or, because I was thinking about immunohistochemistry. If I remember well, at that time there was no guideline. Simply it was introduced and then it started being used, and that's it is. That was happening. So there were no guideline at that moment. Maybe we have some guideline nowadays to use some specific immunohistochemistry in certain areas, for example, breast, I think, because I am in charge of some breast.
HER2 scoring for PD-L1 scoring, things
for
like
example.
That, yes.
But what is your idea, Sara, Juan? Do you think we will need a guideline for the clinical use of artificial intelligence in the clinical practice?
I would say so. But I think it also comes with time. So you first develop the technology, and with starting testing it out in the clinical setting, you will start to see what are the failures, what are the advantages, and I think then all the regulation comes from that. But I would say definitely yes, we need regulation, also to be on the safe side, right? Because if an error occurs, it has to be accounted. So you need to know how to act. And I also like, from the development point of view, there's so many variables that are on the table that, I don't know, some regulation, or at least trying to understand what is indeed a good model, or if that model can indeed be safely used in the clinical setting. You know what I mean? So I would say that yes, we need to still be careful, or at least know what the failures might be, you know, like the range that we have. And I mean, it doesn't make sense to use an AI model that is developed for one task and being directly used for another, right? Like, probably it will fail a lot, and then you will blame the model and not. So there's some constraints that I think we still need to be aware of.
Yeah, couldn't agree more, because, you know, if you bear in mind that perhaps, you know, if you're dealing with a screening situation, like, you know, screening lymph nodes for breast metastasis, for instance, obviously in that situation you want to have a very sensitive test. And sensitivity can you achieve at a certain task? Let's say that you achieve a sensitivity of 99%. That's phenomenal. That is a great model. It is a great diagnostic test. But it is a numbers game, which means that out of every 100 lymph nodes, one of them will be a false negative. So, of course, you know, throughout your career, you'll be look at more than, you know, if this is something that you do in routine practice, you will look at tens of thousands of lymph nodes with the consequent, you know, false negative rate. And obviously, this is something that you want to be able to catch. Another aspect is that, usually speaking, whenever you design a diagnostic test, you always have a choice between sensitivity and specificity. If you make it very sensitive, usually the price that you pay is that you end up with a less specific test, which means that you will have some false positives. So this is going back to our previous point, that you're still going to require a brain to make sense of what the AI is telling you, because, you know, you might have a very sensitive tool. It is inevitable that sooner or later a false negative and a false positive would occur in different orders of magnitudes, depending whether the test is more sensitive or specific. But generally speaking, you know, you do come across many false positives that the AI is presenting to the pathologist. And it takes usually the pathologist a fraction of a second to say, oh, you know what, this is a very sensitive test. It is providing some false positives because that's the situation you have to contend with. But to me, as a pathologist, it's very straightforward to rule that out as a false positive. So that's, you know, something I can easily rule out. But somebody has to do that thinking process, right? Somebody has to, you know, put context into that specific diagnostic situation as such.
So basically, if I get your point, Juan, guidelines for you are not necessary. Simply when you adopt a new test, for example, an AI test, you should take into consideration specificity, sensitivity, and then manage these. Did I understand well, or do I miss something?
No, I think guidelines are required, because not all tests have the same cutoff point.
Okay,
depending.
So the guideline should stress and focus on this.
Right. So
on the features of
Right. So my point is, perhaps, you know, it's up to AI vendors to provide guidance as to how to best use this test for maximal benefit, really, of the diagnostic situation we're dealing with. Again, you know, if it is a screening test, like, you know, it could be in prostate biopsies, for instance, or it could be in lymph nodes, etc. We would definitely need guidance as to, right, what is the false negative rate? In other words, how much trust can I put on a negative result? And what happens with the false positives? How do I deal with those? How do I interpret those? I think it should be down to the individual vendors of that test to basically provide guidance as to how to interpret them into clinical context. Yeah. So I think we're all on the same page there. Yeah.
Thank you.
And of course, there are also diagnostic tests in which you do the opposite. You actually favor specificity as opposed to sensitivity, and you're going to have the opposite situation. How do you cope with those, false negatives? Well, I guess, again, when you design a diagnostic test, you tend to maximize either sensitivity or specificity according to the clinical situation. And, just like, when we were at medical school and, you get that lesson on, what do you maximize? I guess, if it is a screening test, obviously you maximize sensitivity, negative predictive value, etc. But if you want to rule in something, then you do the opposite. You maximize specificity in order to be able to, something that we've found incredibly boring back in those days, but today is very much alive and at the very heart of what we do day in and day out.
Yeah, totally agree.
And also depending on how you use, because one thing is, for example, having the model sorting the cases, right? Like doing that screening. And of course, if you want to rely on that as a first part of the workflow, it really needs like a really high performance and both specificity and sensitivity. But then imagine that you are just testing out some, I don't know, segmentation model to point out like the tumor area or so, and you use it as a second opinion, let's say, like more of a tool. If there you accept a lower performance just because you know that you are taking a decision upon that, you have like a more controlled scenario. So all of these kind of things, these are guidelines. These need guidelines, like how to use or for which case to use, in which scenario, which conditions. Also, for example, the scanners, for example, we know that the different scanners, even with the same flashlight, they might output different images. The models might see it differently, right? So all these little tiny things make a difference in the end. And so that's what we need guidelines for also, in my opinion.
Agree. Generally speaking, I think one of the key advantages of AI really is that based on my experience, and this is not, I've removed my hat of a industry person. I'm not talking as an independent pathologist based on, the evidence that is generated out there and, the papers that are out there. And, most of them actually not industry papers, but actually, independent papers written by by the people who use these tools. I guess the effect of using AI on pathologists is so far in two clear aspects. One of them is greater diagnostic accuracy, because we're all human beings, and it's inevitable that we're going to make mistakes at some point or another and miss a small focus that may be critical for diagnosis because you just have a slow day, because you just had a poor night's sleep, because you're distracted. Maybe you're in a rush because, kids come out of school and you have to rush it. It's inevitable. We are all in those situations. And it's part of everyday life. But the point is, obviously, if you have a very sensitive tool that is telling you this is the area that you need to check first, your performance should basically be more accurate, even in those challenging situations. And we've seen that time and time again in lymph node screening, in prostatic corneal biopsy screening, in pan cancer screening, etc., etc. So I think that's the first impact. The second is the efficiency of pathologists at these tasks. So pathologists using AI, they're not just more accurate, but also more efficient, because we do spend a lot of time looking for needles in a haystack, and the needle may or may not be there. You don't know. You just don't know. You just walk into a haystack and you have no idea how much time should you devote to look in that proverbial needle, because you have no idea if it is there or not. But obviously, if you have a metal detector, your life would be much easier, wouldn't it?
It's easier.
Well, that's the metal detector for you. So that's how you're going to be more accurate and more efficient. So and again, this is something that we see more and more evidence coming out there of how AI actually affects the performance of pathologists.
And maybe another point, reproducibility.
Yes.
Because or at least from my experience, if you are asked to review a case without knowing your previous diagnostic rating, whatever, you'll probably not, you will not agree with your previous, or at least when it comes to scoring and grading, right? And you have to have a number, because it's usually eyeballing, for example, on the immunos. It's it's super difficult for it to match. So if not for more with AI, I think you can help, right?
Yes, agree. And that is definitely a third element that is worth mentioning, that tasks like Gleason grading is incredibly subjective. Things like Ki-67 counting, HER2, if
a lot of tasks, right? A lot of your tests
a lot of them.
Subjective.
A lot of them.
Yes.
Yeah.
So having an AI tool that has a reasonable level of reproducibility, of kappa agreement with whatever the ground truth happens to be, that is another discussion. Like
that is another discussion. Definitely.
What ground truth do you take? Because they're all in these very subjective tasks.
Yeah.
What is the reference standard? Nobody knows, of course. But you have to latch onto something, I guess, and you have to use the best reference that you can grab, I suppose. But the important thing is what you just mentioned, Sarah, is the variance of the pathologist's output is reduced when we use these kind of tools. So yes, there is still variance because nothing's perfect in this life, but it's less so than without this kind of AI tools.
For good and for bad, right? Because if it if it gives an error, it will give the same error. But yeah.
Agree. Yes.
Yes, but at least it's the same. It's reproducible, and you know what to count. Yeah, exactly. Under the same conditions, you know more or less what to count with.
Yes, I would even say that a fourth potential benefit, and again there is evidence. There is evidence by it's a paper published by Katarina Eloy and her team at Ipatimab last month, a couple of months ago, reflecting on the correlation between prostatectomies, who basically had the primary biopsy diagnosed with AI, versus without AI. And it turns out that those biopsies that were diagnosed with AI have much better correlation with the final Gleason grade in the surgical specimen compared to those that did not have. So that's the first thing. So to your point, Sarah, yes, you tend to have better agreement with the ground truth, assuming that the ground truth is the Gleason grading on the surgical specimen. So that's your exactly the point that you mentioned earlier. Second thing is that these patients, actually, these biopsies had a shorter turnaround time of about 1 day. So these biopsies were reported quicker than those in which AI was not used. And a third element is that the pathologist using AI had much better agreement in the group grade ones, so the Gleason 3+3, which is the group of patients who doesn't need to have a prostatectomy, and yet you have the prostate there on your table. So how incredible is that? So in other words, potentially, and this is the conclusion that the authors take on this paper, potentially pathologists using AI have fewer mistakes at overgrading prostatic biopsies, and this may have as a consequence a reduced number of prostatectomies that are not really necessary. So
very interesting.
My point is that the usage of AI doesn't just benefit pathologists, doesn't just benefit the health economic administrators,
for sure,
but also patients that go on not to develop the morbidity and mortality associated with these procedures that may be unnecessary in the first place.
Yeah. Well, and in that sense, we can also go for clinical trials, for example, and trying to, for example, I know breast cancer, it's what I've been working the most with. And for example, some groups of, for example, triple negative breast cancer, that don't respond well to immuno, chemo, whatever it is, the treatment. And with AI, we can go deeper and check, well, but why? What is here that it's different from patient to patient that maybe can give a glimpse of like the reason for this difference in response? And maybe then we can do a better stratification and having better treatments for these particular cases. Right? So it's going beyond to what it's already done and the knowledge that we already have.
Absolutely. Absolutely. I guess, that is so because, pathologists, we've always been trained to look at the epithelial component in the tumor, looking beyond, epithelial components and pay more attention to stroma.
Yes, well, in our group, we really do a lot on for example, stromal lymphocytes, and we have a lot of work on this. So yes, definitely. But yeah, when I say go beyond, is really with AI you can do a lot of things, right? And you kind of have a bit more freedom to explore. I don't know, a lot of variables and a lot of hypotheses. So usually, or at least my approach is usually looking at, of course, with some guidance from pathologists always. But I think I tend to look to have an overlook, like to overall look. So looking for different things that probably you are not paying attention to, or maybe it's not what you usually do. And then what might be even here? So yeah, definitely. And the stroma apparently says a lot, at least the most recent evidence, yes.
Yeah, so sometimes AI models point out to regions of a stroma that would have gone totally unnoticed to a pathologist because we have that bias, isn't it?
Exactly.
Definitely, it's exactly what it is. We started to focus our attention on tumoral cells, not on the microenvironment, but microenvironment is there and might play or plays a major role.
Good. Anything else that we want to get out of our chest before we wrap up?
And maybe we can conclude saying that maybe we need a survey of what's going on the digital transition really in Europe. Inti and Antonio started with this project, but we, generally speaking, we have to conclude, not exactly me and Sara, we have to conclude this, we have to have a true map of what's going on in Europe, because I don't think there is a real perception of what's going on. Sara last time told us that there are many places which are going digital, but I thought about this and I wonder, what does it mean? Maybe they just have a scanner, but they are not digital, so they do not integrate the scanner with the laboratory management system. So really, they are not exactly digital.
But anyway, we have all kind of flavors, right?
Yes, exactly. So I think this is a thing that should be done just to have an idea and to go further. So where we are, to understand where we can go both in terms of clinical activity, so digital completing the digital transition, but also adoption of AI solution, and also about research. And we need the other point, which has been raised by the discussion, is that we need guideline to do this. So once we know where we are, using guideline, we can drive or suggest where to go, at least in terms of clinical applicability.
Yes.
I think we don't need guideline for research. Research should be open as much as possible.
Yeah, but it would be quite good to get real visibility into what is the adoption of digital pathology across the board in terms of how many cases get signed out on a digital basis, percentual wise, perhaps on a region, hospital, country level.
So I think we need
some clarity there would be very welcome. Sara, any final remarks? Any final comments?
No, it's exactly that. to adopt AI, we need digital slides. So that first step is fundamental. And so understanding what is going on in Europe, I think it's really, really important to move forward. And I think that's it. I think we are evolving really fast, at least from the academic point of view and the research point of view. And now it's time to make when it makes sense, right? When the labs are digital and are keen on adopting these AI tools, and then we need the next step, that is bringing all these knowledge and all these models that are being developed to where they should be, that is in the clinical setting.
Great.
Couldn't agree more. Well, it's been a pleasure to have you here today. Very enlightening and invigorating conversation. So thank you very much for your time, and I'm looking forward to seeing you perhaps in Vienna in person.
For sure. Thank you,
Thank
Juan.
you so much.
Looking
Thank you,
forward.
Sara. See you there.
Thank
Bye.
you both. Have a nice day.
Great. Thank you very much. Take care.
Bye-bye.